As a medical assistant in dermatology, transcription of your supervising physician's verbal orders into the written form of the patient's medical record may be one of the most frequent tasks you perform throughout the day. In many practices, providers rarely write their own prescriptions anymore. Instead, medical assistants now often act as a type of scribe, carefully listening to the dermatologist as he or she verbalizes the treatment plan, including the medications to be prescribed, at which time the MA then enters the information into the medical record. For practices utilizing electronic medical records, this process is formally known as CPOE, or Computerized Physician Order Entry. You may have heard this term before. This is because CPOE is a major focus of the so-called meaningful use of electronic medical records. That is, the Center for Medicare and Medicaid Services, CMS, doesn't just want practices to adopt electronic medical records simply for the sake of having them. They instead want practices to, as they put it, meaningfully use electronic medical records. In other words, taking advantage of the increased efficiency and safety offered by the switch to EMR. And part of that includes the safe and efficient entry of medication orders. So why is this such a focus of meaningful use? First, while not every outcome is avoidable, as many as 1 in 4 ambulatory care patients experience a so-called adverse drug event. The cost of medication errors for outpatient clinics alone is estimated at nearly $5 billion per year, and it's estimated that approximately 7,000 deaths occur annually as a result of preventable medication errors. So let's talk about the factors that must be considered with every prescription, and also explore some of the safety features provided by modern electronic medical records. The most important components of prescription order entry for outpatient dermatology patients include patient name, medication name, strength, formulation, quantity per dose, route of delivery, frequency of dose, duration, total to dispense, and refills. While entering the correct patient name on a prescription seems easy enough, prescribing medications to the wrong patient is something which happens every day in the United States. How many times have you encountered a situation like this? A patient with a very common name, we'll say Mary Williams, calls the office and asks for a refill. So you type in her name, and the EMR provides you with multiple options for patients who have that same name. Typically, the date of birth is the best method of distinguishing same-name patients from one another. Of course, if you have the extremely rare bad luck of having patients who share both a name and a date of birth, you'll need to consider other items such as middle initial, address, or even the date of their last visit. Consider this scenario. What if you accidentally pull up the chart for one of the Mary Williams who isn't allergic to sulfa antibiotics, but the patient who is now calling and asking to switch antibiotics is a different Mary Williams, one who is allergic to sulfas? If you've selected the wrong patient from the options, you're not going to see the correct allergy list, nor will you receive a warning from the EMR, advising you to avoid prescribing this class of antibiotic. As reviewed elsewhere in the course, allergic reactions to sulfa antibiotics can be quite serious. At the very least, the mistake would be embarrassing, provided the pharmacy is able to catch the error when she goes to pick up her medicine. If for any reason they don't, though, the patient could be injured. So once you're sure you have the right patient, first and foremost is the name of the medication itself. This is one of the times when those of us working in dermatology should feel very thankful. The reason is that, in our specialty, we really only prescribe a fraction of the thousands of medications available. Imagine the challenge faced by those new to family or internal medicine. In fact, those of you who have worked in dermatology for very long would likely agree that your supervising physician probably prescribes the same 10 to 15 medications for the majority of patient visits. A little later in this module, we'll talk about some of the errors which can occur if you're not careful in selecting the correct medication name. For dermatological medications, the manner in which strength is indicated generally depends on the type of medication being prescribed. Systemic medications, such as pills, tablets, etc., are almost always dosed in milligrams. For example, doxycycline 100 milligrams. For liquids, the manner in which pediatric medications are delivered, the dosage is generally prescribed as milligrams per milliliter, with milliliter abbreviated as ml. For example, cetirizine 5 milligrams per 5 milliliters. Notice where it says 5 milliliters. The strength of nearly all pediatric medications is provided in increments of 5 milliliters. The significance is that 5 milliliters is equal to a teaspoon, a familiar measurement to most people, especially parents. For topical medications, the most common method of medication delivery in dermatology, the strength is almost always indicated as a percentage which represents the concentration. For example, tretinoin 0.025%. For those of you new to dermatology, there's an important point worth mentioning, and that is that while a handful of topical medications are available in different concentrations, many are not. For those, you may find that your supervising dermatologist doesn't necessarily specify a concentration. Topical steroids are a good example. Just about every commercially available version of clobetasol cream is provided in the concentration of 0.05%. Therefore, your physician may simply say clobetasol cream when verbalizing which medication he'd like the patient to use. In doing so, the concentration isn't specified simply because, to them, it's understood. There's only one version. All versions are provided in the same concentration of 0.05%, so why specify? But if you're new, or in any way unsure of what exactly your supervising physician is asking to be entered on the prescription, when in doubt, ask. A medicine's formulation simply refers to the physical state in which the medication is delivered. For systemic medications, the most common forms would be as a pill, capsule, or liquid. For example, fluconazole can be written as 150 milligram capsules. It's worth noting that many dermatologists will not consider there to be a significant difference between, say, the capsule version of a medication versus the pill version of the same medicine. For that reason, he or she may not actually specify a preference. For topical medications, we're generally talking about whether it's delivered as an ointment, cream, lotion, solution, or even as a foam. The various forms in which topicals are available are also known as the medication vehicles, and is a topic we review in greater detail elsewhere in the course. For example, clindamycin 1% solution. But while the formulation of an oral medication may or may not matter, the formulation of a topical is always significant. Solutions have different physical properties and uses than gels, which have different properties and uses than ointments, and so on. So always be sure to indicate the correct medication vehicle whenever a topical is prescribed by your supervising physician. Indicating the quantity per dose of a given medication is really just a matter of describing how many or how much of the medication is to be used each time. When dealing with systemic medications, specifically pills and capsules, the pharmacist and the patient need to know how many to take each time. For example, take 1 or take 2. For liquids, a volume measurement is needed, usually in units of teaspoons or milliliters. For example, take 1/2 teaspoon, or take 2 milliliters. For injectable medications like biologics, the volume measurement is typically in the form of milliliters or cc's. For example, inject 0.5 milliliters. For the topical medications, a specific quantity per dose is usually not indicated. The reason is because there are so many variables which come into play, such as surface area of the treatment site, consistency of the medication, etc. Instead, for topicals, general terms are common. For example, topical steroids are simply written to apply as directed. Sometimes more specific instructions are indicated. For example, apply 1 pea-sized drop, a common quantity description for retinoids like Retin A, Differin, and Tazrac. The route of delivery is the manner in which a given medication enters the body. The vast majority of systemic medications are taken orally. The terms orally, by mouth, and PO can all be used. In fact, PO is really just an abbreviation for the Latin term per os, which simply means by way of mouth. For example, take 1 PO is the formal way to say take 1 by mouth. But again, the abbreviation PO isn't necessary. Instead, it's entirely acceptable now to just write take 1 by mouth. For injectable medications such as Enbrel, Humira, and Stelara, the route of delivery is typically subcutaneously, which can be written just like that, or abbreviated as SQ, subQ, or SC, which all mean under the skin. For example, inject 0.5 milliliters SQ. In dermatology, we generally don't prescribe medications for intramuscular delivery, but it's worth noting that intramuscular, or IM, is the manner in which we document that. Frequency of dose is really just as it sounds. Essentially, how often each dose should be taken or administered. There are really two ways in which the frequency can be indicated. The first is simply by writing it out in plain English. For example, just write it out as it sounds. Once daily, twice a day, 3 times a week, etc. While it's not as fancy as the alternatives, the medical field is increasingly favoring this approach as it provides the least ambiguous method of describing how often a medication is to be used. The more traditional method is to use Latin abbreviations, the most common of which include QD, meaning once a day, BID, meaning twice a day, TID for 3 times a day, QID for 4 times a day, QAM, meaning every morning, and QHS, meaning every evening. While everyone working in medicine should recognize the significance of these abbreviations, it's again worth noting that these days it's entirely acceptable to instead just write out the frequency in plain English. That said, if anyone taking this course is interested in learning more about these various Latin abbreviations, a good resource can be found by clicking here on this Wikipedia page. The designation of duration on a prescription is actually a little bit tricky. At first glance, it would seem that duration is intended to signify how long a patient is supposed to use a given medication. While sometimes the total duration that the patient is supposed to use the medication is the same as what's written, from a pharmacist and insurance standpoint, the duration on a prescription is instead intended to signify how long the prescribed quantity is supposed to last. For example, 14 days or 30-day supply. Consider the following scenario that those of you working in dermatology have probably seen many times in the past. A patient is prescribed clobetasol for a rash on the chest and back. Here's what the prescription looks like. Here we see that a 60-gram tube has been prescribed with a duration of 14 days. Because the patient has so much surface area involved, he ends up using the entire 60-gram tube in just 8 days. He then calls the office, upset, stating that the pharmacy won't refill his medication because it's too soon. So what happened? What happened is that the pharmacy, and for that matter his insurance company, sees that the original prescription was written to suggest that a 60-gram tube should have been a sufficient quantity for the 14 days of treatment. Therefore, based on the prescription, the patient isn't allowed to refill the medication until 14 days has passed. This is one of the reasons why it's so important to specify the quantity of medication, be it pills, creams, gels, etc., which is truly sufficient to last for the duration indicated on the prescription. The total to dispense is just as it sounds, that is, how much medicine should be provided in each prescription. For example, an antibiotic to be taken BID for 1 month would be written to dispense 60 tablets, or simply number 60. An Efudex prescription to be applied QD times 3 weeks to the face may be written to dispense 40 grams. Or a patient receiving a Stelara injection every 3 months may be prescribed a dispense quantity of 0.5 milliliters. And last, perhaps the easiest of the prescription components to understand is that of refills, a term which really needs no explanation. How many times can the patient return to the pharmacy for an additional supply of medication without a new prescription being called in? While it may seem like a minor detail, you should always confirm the number of refills authorized by your supervising dermatologist. To understand how important this can be, just consider the worst-case scenario of what might happen if too many refills were authorized and the patient kept refilling medication without actually following up as directed. If a strong topical steroid were refilled countless times and overused, it could result in steroid atrophy. A patient taking systemic antifungals for too long and not complying with follow-ups or lab work could suffer liver damage. And what if a patient on dapsone kept no-showing for follow-ups, yet at the last visit, the MA mistakenly approved 10 refills, so the patient kept going to the pharmacy and getting more, even though he wasn't following through with having his CVC monitored. He could become significantly anemic, but wouldn't know it until the symptoms got so bad that he had to be hospitalized. These are really just a few examples. So again, just be sure to confirm the number of refills before entering them into the system and sending off the prescription. We're going to talk now about some of the more important considerations for avoiding medication errors. Let's start by clarifying what is and what isn't expected of you when it comes to prescription order entry. First, as a medical assistant, you are not responsible for exercising independent clinical judgment with regard to medication selection. That's the job of the dermatologist, physician assistant, or nurse practitioner you work with. However, when you play a role in entering their medication selection into the EMR, you are responsible for 1. Accurately entering the previously prescribed prescription details as communicated by your supervising dermatologist, and 2. Recognizing and acting upon any clinical decision support or CDS alerts which are intended to assist in preventing errors such as medication allergies and interactions. You may have heard about how the Center for Medicare and Medicaid Services requires medical assistants to be credentialed or their order entry activity will count against meaningful use. Well, this is at the heart of why they've created that rule. They want to ensure that those who are playing a role in order entry have a sufficient knowledge base to effectively avoid errors in medication entry and to also act upon any pertinent CDS alerts. So let's start with avoiding errors in order entry. The first step to avoiding errors when prescribing is to enter the medication name and directions precisely as described by your supervising physician. This sounds easy enough, but there are a number of factors which can stand in the way of accurate prescription entry. First, pay attention. Those of you who have worked in dermatology for very long can probably recall an MA you've worked with who was repeatedly prone to sending in either the wrong medication or the right medication but the wrong directions. At the very least, the pharmacy calls and asks for clarification, or at the very worst, the patient would receive the wrong medicine and use it incorrectly because the wrong details were entered. Medical assistants and nurses should always put distracting personal issues aside and avoid multitasking while the physician is verbalizing the prescription details. Second, don't be afraid to ask if you're not sure. This cannot be overemphasized. Even if there are no distractions, there will be times when you simply didn't hear everything that was said. Every day, mistakes are made because the MA entering the prescription information didn't hear or understand the details, but was too proud to ask for clarification. Foolish pride should always take a back seat to patient safety. Next, beware of Soundalikes. Earlier in this module, we talked about how the medication name is of course one of the most basic and important components of entering a prescription. As basic as it sounds, it's actually a common source of medication errors. Did the doctor say hydroxyzine or hydralazine? Did she say fluorouracil or was it fluocinamide? Can you imagine what might happen if a patient has contact dermatitis, but instead of sending fluocinamide, a common topical steroid, fluorouracil or Effudex was called in? Try explaining that to the patient when they call and talk about how their inflammation is now so much worse. Once again, the key to preventing this mistake is to pay attention and don't be afraid to ask if unsure. We should also avoid confusing terminology. It's worth remembering that abbreviations, acronyms, and shorthand were all designed to speed up the handwriting process. With electronic medical records, there's no reason we can't just type out the directions in plain English. For example, instead of entering QD, just write once daily. Or rather than writing TIW, why not spell out 3 times per week? We'd like to think that most pharmacy staff are familiar with these terms. But in the end, human error is possible every step of the way. Why not just make it as unambiguous as possible? When in doubt, just spell it out. It's also well known that so-called trailing zeros should be avoided, as they just add potential confusion when it comes to entering quantities. For example, entering spironolactone 25.0 milligrams just invites the opportunity to misinterpret the entry as 250 milligrams. Instead, it would be best to simply keep it written as 25 milligrams. On the other hand, we should include leading zeros. For example, the concentration of 0.1% with no zero in front can be easily mistaken for 1%. In this example, it would instead be best to write 0.1%. The zero helps draw attention to the decimal point, which is the key factor in identifying this concentration as a fraction of 1%. Rather than a full 1%. Moving on to what is perhaps one of the most important benefits of electronic medical records in CPOE is that we must all recognize and take action when presented with important clinical decision support alerts. This term may not be very familiar to everyone watching, but anyone who has used electronic medical records will certainly know it when they see it. CDS alerts are the sometimes annoying pop-up alerts we occasionally see after patients' prescriptions are entered into the medical record. For example, let's say that a patient is prescribed doxycycline, but the physician didn't realize that he has reported a past history of hive-like reaction to minocycline, which of course is another antibiotic in the tetracycline family. So once all the details are entered, this CDS alert pops up. We can see here at the top of this very important warning, the use of doxycycline may result in an allergic reaction based on a reported history of allergy to minocycline. Obviously, this is important. If this patient were to take the doxycycline, he could potentially experience a significant reaction and be injured. Besides obvious allergies, these same CDS alerts can provide a variety of advisories which enhance patient safety and ensure medication effectiveness. Here we're reminded that patients should avoid taking doxycycline with dairy products since, as with all tetracyclines, calcium decreases the absorption of the antibiotic. Would it hurt the patient to take it with milk? No, but it decreases the effectiveness. So not all alerts focus on life-threatening issues. Medication interactions can trigger these alerts as well. For example, let's say a patient is about to be prescribed methotrexate, but the physician didn't notice that she is taking aspirin every day. After the MA enters the methotrexate into the EMR, this alert pops up. It tells us that the aspirin she is taking may increase the plasma concentrations of methotrexate, which can in turn increase the risk of bone marrow and hepatic toxicity. So whether warning us about the potential for overt allergic reactions or even medication interactions, these CDS alerts have the potential to prevent patient harm. That said, almost everyone who has worked with electronic medical records has realized that not all CDS alerts are important. In fact, many of them aren't important, and this can lead to something known as pop-up fatigue. How many times have you seen something like this? Let's say a psoriasis patient comes in for follow-up and requests refills of his clobetasol cream. However, while he's here, he just happens to have an abscess on his back that he needs to get incised and drained. So after entering his clobetasol prescription into the EMR, this alert pops up. Here we're told to exercise extreme caution in prescribing clobetasol cream. Why? The reason is because the code for abscess sets off the alarm for cellulitis, which of course is an infection. Well, as a general rule, infections shouldn't be treated with steroids. However, your supervising dermatologist isn't treating the abscess with clobetasol. He's treating the psoriasis with clobetasol. But the EMR doesn't recognize this. Warnings like this are what create the so-called pop-up fatigue mentioned previously. That is, if the majority of CDS pop-up alerts you see are irrelevant and have no merit, what happens? As humans, we start to tune them out, and before you know it, we don't pay attention to any of them, including those that are significant. This is an issue that all practices need to address head-on, and a protocol for how to handle these CDS alerts should be established which ensures patient safety while avoiding unnecessary disruption of workflow. In summary, and what's really the bottom line when it comes to prescription order entry, is that while medical assistants aren't expected to make independent decisions regarding medication selection or formulation of the treatment approach, you will be expected to responsibly enter any medication orders. This means that you must accurately transcribe your supervising physician's verbalized medication order while simultaneously heeding important clinical decision support alerts. We cannot overemphasize how important this duty is when it comes to patient safety. If for any reason you aren't up to the task, do yourself, your supervising physician, and your practice's patients a favor and excuse yourself from performing this function.